Bartosz Chmielowski from UCLA is our next speaker up, and we've known each other for a little while, but really happy and excited to have him here to talk about some of the newer things that are back in skin melanoma in dealing with patients who have a high risk of it coming back and ways we can lower that risk. So with that,
Okay, thank you for inviting me here. In the next, hopefully 20 minutes, I'll tell you a little bit of the therapies we are trying to use to prevent recurrence of melanoma after surgery. And of course, there is a humongous progress in treatment of metastatic disease. But in the last few years, we've been doing also quite a lot of progress on moving these therapies earlier to offer for the patients who are at risk for recurrence after surgery. So, how do we manage surgically? So this is a very brief summary. So, of course, these are the patients from my clinic. You already saw in the first presentation several different melanoma lesions on the skin. As you can see, they may have a different appearance, different flavors, but you go to your dermatologist, undergo biopsy, and you receive a diagnosis of melanoma. When we think about the prognosis and staging of melanoma, we look at several features. We look, how deep it goes into the skin? Does it have something what we call ulceration? Did it travel to the local lymph nodes? And of course, did it travel to other parts of the body? Based on this, we get the stage of melanoma. And if it's only on the skin without lymph node involvement, you have a localized disease. If there's lymph node involvement, still there are surgical options. If it travel to other parts of the body, surgery would have a limited function in this case because it's already in other parts of your body. So traditionally in these patients, as you saw, you see the primary lesion, your biopsy showed it's melanoma. You go to a surgeon, they inject, when they plan for surgery, they inject a dye to find the closest lymph node. So we assume we know that melanoma likes to travel to the lymph node. So if you inject the dye will choose the same pathway melanoma would choose to travel to the lymph node. And this is radioactive dye, so it can be detected, and this is what we call our sentinel lymph node. So when the surgeon does the surgery, they do undergo white excision and then sentinel lymph node biopsy to assess the closest lymph node. If you already have enlarged lymph nodes, or if your sentinel lymph node was positive, in the past, in VP, everybody who has positive sentinel lymph node, they were removed. Other lymph nodes from the same area were removed. Today, we don't do it so often, but if you have multiple positive lymph nodes already on your exam or so, then still, it remains a standard of care. We are trying to change it, but to remove all the lymph nodes from this area. And this is something what we call lymph node dissection. I told you already about stages. Stage 1 and stage 2 is only localized disease. Stage 3 is the one that traveled to the local lymph nodes, for simplicity. Stage 4 is the one that traveled to other parts of the body. On the right side, you see the stage 1 patients and stage 2 patients. On the left side, you will see stage 3 patients. And one thing which I wanted to point out, although you might have a lower stage, let's say here the green curve shows stage 2B, and the higher on the curve you are, the better your outcome. So this is how many people survive depending on the stage. So if you have stage 2B, the 10-year survival is 82, but actually this is actually worse survival when you had as patients with stage 3A, which are 10-year survival is 88. If you had stage 2C disease, then your survival is very similar to patients with stage 3B disease. So it shows the weakness of our staging system, but not always lower stage means that you have a better prognosis, but also it indicates for us when we need therapies, not only for stage 3 patients, so the ones who have spread over disease already to the lymph nodes, but maybe even to patients who have just the skin lesions, depending on your stage. I'm not going to go into details of that, but so when we think about principles of the therapy, I think it's extremely important for the patients and for us to understand the principles of the therapy. This slide is probably right now 15 years old or 20 years old. But it still holds. We can have two methods of the therapy. We can target the tumor, and this is what traditional chemotherapy is doing in multiple cancer. We don't use chemotherapy so often, but we do look for these mutations which I mentioned, so we can target the particular mutations in melanoma and use it in what we call it a target therapy. But we can also use the immune system, and when the immune system is not necessarily part of the tumor, it's our natural defense mechanism against bacteria, viruses, or organs, but we can use the same immune system, and then this is indirect fighting of cancer. So in immunotherapy, immune system is very good, not only because it's quite specific against, specific mutations or antigens which we can find in bacteria, viruses, but also in the tumor. It can be adjusted, and it has a memory. So it's a good mechanism to fight cancer. And where we have our immune system is has a very broad specificity. Generally, we have two important group of cells, like such as T cells and B cells that produce antibodies. That's why our immune system can protect us so well from all the viruses and bacteria which are all around us, because we have so many different specificities, and we can adjust. Once the antigen is identified, then the cells proliferate and get rid of bacteria. Why is it not so easy to use the immunotherapy? We've made humongous progress in patients as a part of treatment of cancer. So some patients when come to my office say, what can I do to boost my immune system? Because we always talk about immunotherapy, how we are going to use it. And I often am disappointing them, because their immune system works perfectly well. If it wouldn't be working, they would be getting infections all the time. So it's not a failure of immune system. It is that your cancer outsmarted your perfectly working immune system. So this is one of the things. The second thing, our immune system generally is designed to get rid of foreign. So if bacteria or viruses, which don't belong to our body, we get rid of it. But cancer comes generally from our own cells, or not generally, it comes from our own cells. So although cancer is abnormal, resembles your own normal cells very much, and our immune system is designed not to get rid of self. So luckily they are not identical. We are depending on these differences between abnormal and normal cells, but this also makes it difficult for our immune system to use immune system to fight cancer. We already talked about mutations in melanoma, but what I wanted to say is where people were looking at multiple melanomas, the most common mutations are in the protein called BRAF, and the most common is V600E mutation. Then the second group would be NRAS and F1, and then there are some other mutations which can happen in melanoma. I don't want you to fully understand this. I just want to show that about 40% of melanomas contain mutation in the protein called BRAF. So I already showed you if you undergo surgery, the patients are at risk. Then although the surgery went completely well, the surgeon comes out and says, I got it all. But go and talk to an oncologist and see what he's going to say. And when you come to an oncologist and the oncologist disappoints you, yes, the surgeon got it all, but you have 50% chance then there is something else hiding in the body, or 20%, or whatever, depending on the features we discussed. So now you're coming and say, can I make a difference and improve these chances? So right now we have several therapies approved. They're actually more approved, but these are the ones which are in use. So either the immunotherapy drugs, which are what we call PD-1 blocking antibody, pembrolizumab or nivolumab, or if your melanoma had BRAF mutation, then you have another option, which is a targeted therapy. And right now, the combination of dabrafenib and trametinib is approved in this population. All therapies are given for 1 year. A surgery as a prevention of recurrence. So you are followed with physical exam and imaging study while you're on the therapy, and you finish the therapy and you are still followed to be sure when the disease did not come back. I don't want you to fully understand these curves, but it shows that upper curve means you did better. Lower curve means there is a higher chance for recurrence. And I showed you several several very similar curves showing that pembrolizumab for stage 2 melanoma, there is a difference between people who received pembrolizumab and people who did not receive pembrolizumab. I just want you to remember then the brown curve says they did not get it, so they were treated only with surgery. So it does not, I'm not saying that surgery is a bad thing. You know, as you see, majority of patients still got cured with surgery, but unfortunately many did not, and we are trying to improve it. So this is what makes the therapy after surgery difficult, because you know that you talk to one patient, but if you know that you look at the all group of patients, some are already cured, but you will be giving them therapy. So, and you don't know who it is. So you're giving the therapy, they're at risk for side effects. You have to treat everybody, but you know that you benefit only % of it. Similar results for nivolumab. We are not going to go detail into numbers. I think this is for stage 3. For stage 3, these drugs were approved first, so we have a longer follow-up. But again, this is a pembrolizumab curve, and this was a placebo curve, so there was a differentiation between these two. This is for nivolumab. Nivolumab was actually compared to other drug, which we also use right now mainly for metastatic disease, called ipilimumab. The difference is smaller just because they did not use placebo as a control arm. But in targeted therapy, we have very similar curves, and I'm not going to go, as I say, we are not going in details into numbers, but you see the targeted therapy has also good separation between people who receive targeted therapy, dabrafenib, trametinib, or placebo. A lot of patients ask about this trial. So as we know, COVID vaccines, where a COVID vaccine was a huge success in prevention of severe COVID and prevention of infection. But actually, with RNA vaccines were initially developed for cancer, just the development kind of slowed down because the COVID infection came and was easy, and this actually expedited the development of these RNA vaccines. So Moderna came up with this vaccine. So what if we take the tumor and try to find the antigens or the antigens which are different and create the vaccine and use it in combination with pembrolizumab? It's a little bit more difficult than with COVID vaccine because COVID, we know the structure of the virus, so we can make it, it can be on the shelf. Here, every melanoma is different, so you have to have a sample from the patient and create for each patient a separate vaccine. In our early trial, we see quite a nice separation, so improvement. This one, the bottom curve shows right now pembrolizumab alone, but now pembrolizumab plus vaccine. The confirmatory trial showing when this is real is ongoing, and we'll see, if we can improve over what we have already right now. The reason I talk to you, when it's so important to think about this therapy, why not to give everybody? Yes, we would like to give it to everybody, but we have to remember when they can come with significant side effects, and I'm not gonna go into details, but and the side effects sometimes are life-threatening, and 1 per 100 people can die because of adverse events, or they can be permanent after the therapy. So you have to really think what's your acceptance of risk and what are the chances that your disease will come back after surgery. Because if you have stage 1 disease and you have maybe 1 or 2 or 3% chance of recurrence, somebody will recur, but it means that 97% of people will be treated for no reason. And on top of that, about all people will be at risk for side effects. So this discussion is extremely important when you make decisions to treat or not to treat. Now, now we say, can we do even better? So what if it's a little bit different patient population, but what we already know when the lymph node is involved by cancer? Sometimes we don't know, only the surgery shows us, but what if a patient comes with already swollen lymph nodes, or you did your scan and the lymph nodes are enlarged? Can we do something? Maybe we should start therapy before the surgery rather than after surgery. And it's assumption that maybe immunotherapy will be working better. Let me explain to you. We know that the immune cells are attracted to cancer, attracted to tumor. So if they are attracted, very often they sit in this tumor. So if you undergo the surgery, majority of the cells which are supposed to be fighting, your immune cells fighting the tumor, are removed with the surgery. So we know that there is a risk that there is some residual tumor left behind. So you know that not all the cells are removed. But they say, but you are actually removing the fighters with the surgery, and now you are coming with immunotherapy afterwards, hoping that you are going to stimulate the fighters. But many of them were already removed during the surgical procedure. So what if we try to activate the cells before surgery? So they are already active, then you undergo surgery, but you already have activated cells in your body that can continue fighting possible residual cancer. So that's why with SWOG, Southwestern Oncology Group, you ran this clinical trial. Everybody got the same therapy, 18 doses of pembrolizumab and surgery. But half of the people got just 3 doses before surgery and then went to surgery and then finished their pembrolizumab. Half of the people got surgery first and they got pembrolizumab. I have to say, I had patients who had anxiety about it. They say, oh my God, you are gonna leave my tumor in the body, allow it to grow while I'm getting therapy, and I'm not gonna have surgery immediately. But what we actually saw, then there's a 20% difference if you got your therapy before surgery. So now if this is the first time when we see an evidence, then it's not only important what you get, but the sequence and when you get it. It's not every patient with melanoma, I repeat, because you have to have evidence of involvement of lymph nodes before the surgery is done. Because if you learned that when lymph node was positive after surgery was done, then of course it's already done. But if a patient have, then right now we say, don't go immediately to surgery. I know it's stressful because your tumor stays in the body and the doctor tells you it's going to be another 2 months in the body before you undergo surgery. But you're going to do so much better if you get the therapy before. So we are trying to make it even better. What if we do nivolumab, ipilimumab? So combination, just 2 doses of treatment. And I'm not going to the details of this, but it clearly shows that more than 60% had, when they went after the 2 doses of combination treatment, more than 60% of patients had no melanoma left in the lymph node. And these patients, as you see, almost no one developed spread of the disease, and very few patients recurred. If there was residual melanoma, and they did not undergo any other treatment, so they underwent the 2 cycles of immunotherapy and removal of the positive lymph node, and then the majority of people did not have melanoma in this lymph node. But if there are other patients who had residual melanoma, they do not do so well. It means when they do need some additional therapy, the 2 cycles might not be sufficient. So this is something to think as, can we minimize the surgery? Can we shorten the therapy? So these are the future questions for which we have. So can we, right now it remains, if you have enlarged lymph nodes, it remains a standard when your surgery will remove all the lymph nodes from this area. But if we use the successful therapies, can we omit it and remove only the lymph nodes that are enlarged, but leave the rest behind? There will be lower risk of swelling of the arm or the leg. There is a lower risk of infection. So then again, what we see, how do we gonna differentiate? You remove the lymph nodes. You already know that people who, if you cannot see any viable melanoma, these patients are gonna do well. What about the ones who have some? What's the right? Should we change the therapy after that, or should we continue the same therapy for profound? So these are the questions we'll be asked, where we are trying to answer. Will be the time when we can eliminate surgery completely. Surgery will be still an important method of treatment for melanoma, for different, but we will hopefully find a different function for surgery or different time for surgery. So it's not like when there will be complete elimination. And again, we already talked about when you make your decisions, you cannot forget about side effects, because some side effects can be life-threatening. Some side effects will persist for the rest of your life. But of course, if your risk of coming back of a disease is very high, I think it's worth taking this risk because melanoma can take your life. But if your risk of coming back of a disease is low, you really have to think, is it worth, getting the therapy and taking the chances of side effects. All right, that's all. I think it was a sprint presentation, but hopefully gave you a general impression.